Today, our topic of discussion is the neuroprotection and aortic surgery. First of all, just I want to say that this aortic surgery and neuroprotection, it is a huge topic, and it covers both the ascending aorta, arch of aorta, descending aorta, and the abdominal aorta part. And so I just divided the whole thing into two. One is the first ascending aorta arch and the thoracic, and the second part is the abdominal aorta. So, before going to the the neurological problem in aortic surgery, I just want to just say something about the general consideration for the aorto-surgical patient, because it starts from the pre-surgical evaluation, pre-anesthetic evaluation, proper history, and today, nowadays, the point of medical issues is huge. So minute details of the patient's previous history is so important, because after the surgery there could be a stroke, there could be a type 2 neurological dysfunction, various types of problems, or it could be something related to the spinal cord ischemia, the effect, paraplegia, paraparesis, and all these things. So prior taking the patient, neurological evaluation, proper history taking, details examination of the physical status of the patient is so important, and we need to get the sign of the patient party and the patient that we are going to do all these things, and we should discuss the whole thing to the patient and the patient party that we are going to do all these things, and these are the complications and all these things. So the urgency of the operation, particularly whether the surgery is emergent or urgent or elective, that should be discussed. The pathological and anatomical extent of the disease is very important, because that dictate the course of the surgery and the outcome. And also the involvement of the artery, involvement of the aorta, whether that has involved the arch or descending thoracic aorta or abdominal aorta, that will decide our surgical approach, whether the median sternotomy or through the thoracotomy approach, or nowadays the endovascular approach. And also from anesthesiologist point of view, we should also consider the mediastinal mass effect due to this huge dilatation of the aorta, or ascending aorta, or descending thoracic aorta, and that there could be a possibility of the aortic compression or deviation. So all these things should be kept in mind. So pre-existing or associated medical conditions that can lead to a post-operative neurological dysfunction, there are lots of problems. There could be lots of problems. But we should, in this discussion, we should consider only the neurological point of view, neurological problems. That is the previous history of aortic valve disease, aortic tamponade, coronary artery disease, cardiomyopathy, particularly the cerebrovascular disease. Minute details of the problem should be addressed. And also the preoperative medication of the patient, whether the patient was taking any warfarin or any antiplatelet therapy or any antihypertensive drugs, because in the previous slides we will discuss that to maintain the spinal cord perfusion pressure, we need to augment the pressure. So before all the hypertensive drugs, because we should stop the ARB or the AC inhibitors to maintain the blood pressure and all these things, that are all important. So anesthetic management, we should, from the monitoring point of view, we should monitor the hemodynamic monitoring, proximal aortic pressure, right plus minus left radial pressure. Every radial pressure, either right or left, they have the separate indication whether we should only monitor the right or only monitor the left, or both. And also the distal aortic pressure, like the femoral artery pressure, and we should also monitor the central venous pressure, PA pressure, and cardiac output monitoring, and obviously the transesophageal echocardiography. So neurophysiologic monitoring, see, theoretically we should monitor all these things like EEG, somatosensory evoked potential, motor evoked potential, jugular venous oxygen saturation, lumbar cerebrospinal fluid pressure. Normally we do that lumbar cerebrospinal fluid pressure, body temperature, both core and periphery, because in the due course of rewarming that the difference of these two temperatures is very important. And also the near infrared spectroscopy NIRS. So though the role of this NIRS is very controversial, some people are saying that this NIRS does not reflect the true oxygenation of the cerebral hemisphere. Some studies are showing that it's okay. At least it will give some broad idea about the cerebral oxygenation. So these are the available neurophysiological monitoring. But from in our institution, from day-to-day life, during this complicated surgery, we normally monitor that NIRS and body temperature, and obviously the lumbar cerebral fluid pressure. So the mode of ventilation during the aortic surgery, that sometimes we need the double lumen endotracheal tube and or the endobronchial blocker. Potential for the breathing, what are the max A points? Large bore intravenous access should be there. Blood product available, there should be available. Anti-pulmonary therapy and antibiotic prophylaxis should be taken care of. So post-operative care consideration and the complication. There could be hypothermia, hypotension or hypertension, bleeding, spinal cord ischemia, that is very important from our point of view, from our today's point from the discussion, stroke. Then there are lots of things: renal insufficiency, respiratory insufficiency, phrenic nerve injury, diaphragmatic dysfunction, recurrent nerve injury, or pain management. So thoraco aortic aneurysm surgery, why the temporary interruption of the cerebral blood flow, definitely there will be a temporary interruption. So what are the problems? What are our concerns in this surgery? First is the stroke. So what are the mechanism of the stroke in this aortic surgery? First is the cerebral ischemia due to hypoperfusion or temporary circulatory arrest. Definitely we are going to do the DHCA or MHCA. Or cerebral ischemia due to embolization secondary to CPB or atheroma. So the arterial emboli, it could be air, or it could be a particulate due to several products. So arterial emboli due to air introduced in the circulation from the open cardiac chamber, vascular convolution site, or arterial anastomosis. And atherosclerotic particulate that dislodge during the surgery, during the clamping or declamping time, creation of the anastomosis in the ascending aorta or aortic arch, or excision of the severely calcified valve. And also there are some complications due to the CPB, particularly the microparticulate aggregate of platelet and fat. And the turbulent high velocity blood flow may dislodge atherosclerotic debris. And there could be a problem due to retrograde blood flow through the disease TTA, distal thoracic aorta. So what are the neuroprotective strategies? First is the deep hypothermic circulatory arrest. Second is the topical cerebral cooling, controversial. Retrograde cerebral perfusion, not used very much in nowadays. Selective antegrade cerebral perfusion, very important. And cerebral hypothermia, cerebral hyperthermia prevention during the rewarming. So first, coming to the deep hypothermic circulatory arrest. Why it is so important? Now, the first thing is the brain is very susceptible to the ischemic injury due to the high metabolic rate, continuous requirement for the metabolic substrate, and limited reserve of high energy phosphate. That's why brain is so susceptible to ischemia or hypoperfusion. Now, physiological basis of this DHCA is to decrease the cerebral metabolic rate and oxygen demand. Now, evidence also says the autoregulation of the cerebral blood flow is maintained during the DHCA with the alpha state blood gas management without compromise of the clinical outcome. So now it is very astonishing that there is no optimal protocol for this conduct of deliberate hypothermia. So normally what is the normal practice, that average nasopharyngeal temperature, which is the core temperature for DHCA, is about 18 degrees centigrade. But the question is, why it is 18 degree? Why it is not 17 or 16 or 12 or not 20 degree? Why it is defined at this 18 degree? Now, the main problem is that we are unable to measure the direct brain temperature, and for that reason, what are the options we have? First, the EEG or the jugular valve venous oxygen saturation. And it has been seen that DHCA alone, it is the excellent neurological outcome. It gives an excellent neurological outcome. And the technique of DHCA alone is a reasonable approach for neuroprotection during aortic arch surgery in the setting of adequate institutional experience. It is very important. Now it is a class 2A recommendation, level of evidence B. Role of tropical cooling is controversial. No benefit, or some say that there is a potential harm in this tropical cooling, and it also interferes with the EEG or cerebral oxygen monitor, and it is also an institutional practice. Now, DHCA extends. What is the benefit of this DHCA? It extends the CPB duration with consequent risk for coagulopathy and embolization. You know, there are three components. One is the DHCA, another is the DHCA with antegrade cerebral perfusion, whether it's selective, it could be the selective ACP to be unilateral or bilateral. And another nowadays, which is coming nowadays, is the medium hypothermic circulatory arrest with ACP. So initially the people started doing this only the DHCA. What is the benefit of the DHCA? It extends the CPB duration, but you cannot prolong the CPB duration for a long time because there is a problem with the coagulopathy and the embolization. So rewarming also can aggravate this neuronal injury, and to maintain a temperature difference not more than 10 degrees between the heat exchanger and core temperature during the rewarming time. And also we should monitor the temperature between the core temperature and the peripheral temperature that should not exceed 3 degrees centigrade. And we should also avoid the cerebral hypothermia, that is nasal-vision temperature more than 37.5 degrees. That is a class 3 recommendation, level of evidence B. Now, along with this DHCA, there are two options. This one is retrograde cerebral perfusion, another is the antegrade cerebral perfusion. First, we will discuss the retrograde cerebral perfusion. This cerebral perfusion technique performed by the infusing cold oxygenated blood into the SBC cannula at 8 to 14 degrees centigrade via CPB. I have not given any this diagram because to explain this diagram it is a time-consuming thing. So that's why I just omitted that's the whole circuit. IGB pressure maintained at less than 25 millimeter Hg to prevent the cerebral edema. And this IGB pressure is measured from the introducer part of the IGB catheter at a site proximal to the SBC cannula and zeroed at the level of ear. And patient position should be 10 degree Tenderberg to decrease the risk of cerebral ear embolism and to prevent the trapping of air in cerebral circulation. Now, the RCP flow rate should be 200 to 600 ml per minute. Potential benefit of the RCP, what are the partial supply of the cerebral metabolic substrate, embolic washout, and maintenance of the cerebral hypothermia. Still, it is not a standard technique for neuroprotection in DHCA. So there is a balance between DHCA with RCP versus moderate hypothermia with ACP. Lots of debate which path we should take, which is a better modality. But nowadays, people are going more towards the moderate hypothermia with ACP. Now, selective antegrade cerebral perfusion. It is considered for the aortic arch repair longer than 45 minutes, and DHCA with selective ACP is superior to DHCA alone. It is very important because nowadays, normally, when there is an arch, all the arch vessels are involved, we go for the this DHCA with the antegrade cerebral perfusion. Now, how it is done? The selective cannulation of the right axillary artery or right subclavian artery or brachiocephalic artery or left common carotid artery is done, and or inserting an individual perfusion cannula into the open end of the aortic branch vessel after opening the aortic arch. So after opening the aortic arch, they put a separate cannula in the left common carotid, the separate cannula in the left subclavian. And also definitely initially they also definitely put in the either in the axillary artery or in the subclavian artery or the brachiocephalic artery. And the oxygenated blood at 10 to 14 degree at a flow in the range of 250 to 1000 ml per minute to achieve a cerebral perfusion pressure of 50 to 80 millimeter of mercury, because this cerebral perfusion pressure we should monitor in the right radial artery. Now, unilateral or bilateral ACP. So unilateral ACP, it is via the right axillary artery. It is very common. Assumes an adequate cycle of Willis. We are assuming, note that. And anatomic completeness of the cycle of Willis does not guarantee cerebral cross perfusion. Now, what the surgeon does after when they go for this unilateral ACP, they first start giving this cerebral perfusion through the either through the brachiocephalic or the or the right axillary artery. Now they clamp the brachiocephalic, they clamp the left common carotid, and also clamp the left subclavian. Now, after giving this perfusion, they just declamp the clamp in the left common carotid. If the flow from the left common carotid is adequate, they assume, note, they assume the cycle of Willis is intact. So sometimes they give only the unilateral ACP. The point is, anatomic completeness of the cycle of Willis does not guarantee a cerebral cross perfusion. So to be in a safer side, we should preferably give bilateral antebrachial cerebral perfusion. And it is essential to monitor the contralateral hemisphere with the cerebral oximetry, carotid artery scanning, or transcranial Doppler. Now, which ACP is superior, unilateral or bilateral? Study says stroke rate similar, but the period of safe ACP is prolonged in the bilateral ACP. And the recent meta-analysis demonstrated in aortic arch reconstruction both achieved a similar outcome for perioperative mortality, stroke, and delirium. So from complication point of view, both showing the same result. Now, there is another point, DHCA with the ACP versus MAC, that is moderate hypothermic circulatory arrest with the ACP. MAC with the selective ACP appears to be an adequate technique for adult aortic repair, aortic arch repair. Safety is limited in the setting of the elderly, multiple comorbidities, and extended operation time. And overall, DHCA with the ACP is reasonable in the setting of adequate institutional experience. Now, what are the pharmacological neuroprotection strategies for the DHCA? There is no proven pharmacological regimes. What are the agents normally people use? Fentanyl, we use thiopentol, propofol, steroid, magnesium sulfate, and lignocaine. And that should be considered as the neuroprotective adjunct, not the substitute for the hypothermia. And DHCA with the pharmacological adjuncts is reasonable approach. It is a class 2A recommendation, level of evidence B. Now, coming to the next part, the descending thoracic and thoracoabdominal aortic aneurysm. We know the proper classification of thoracoabdominal aortic aneurysm. Clinical outcome of the TAAA repair operative mortality is very high. Permanent spinal cord deficit, stroke, acute renal dysfunction, cardiac complication, pulmonary complication, bleeding, recurring re-exploration. So now mortality and the paraplegia after the thoracoabdominal aortic aneurysm repair, from a neuro complication point of view, TAAA extend 1, 2, 3, 4. Now see the operative mortality is 6.7% in case of TAAA extend 1, in 2 9.1, in 3 12.7, and 4 5.7. But the permanent paraplegia or permanent paraparesis, it is huge. Now descending thoracic and thoracoabdominal aortic aneurysm, the operation, the mode of operation, I mean the operative surgery, the strategy could be different. The simple aortic cross-clamp technique, it totally depends upon the extent of the aneurysm, or they can use the Goldson or the partial left heart bypass, CPB with the DHCA, or the endovascular stent graft repair of thoracic aortic aneurysm. This is a new one, very popular nowadays. So simple aortic cross-clamp technique. Why I am giving this this picture and all these things just superficially, because all these things are related to the complication of the neurological complication. They put just to clamp just proximal and distal to the aneurysm. In the Goldson, they put a shunt from the proximal to the distal part, partial left heart bypass, and CPB with the DHCA, normal CPB with the DHCA. Now, why this distal perfusion is so necessary? And what is the potential advantage? Control of the postural hypertension, decrease the left ventricular afterload, less hemodynamic perturbation with aortic clamping and unclamping, decrease the duration of the mesenteric ischemia, decrease the risk of paraplegia, paraplegia from the spinal cord ischemia, very important. Ability to control the systemic temperature with heat exchanger, vascular access for rapid volume expansion, ability to oxygenate blood with extracorporeal oxygenator, and maintain the lower extremity SSCP and the MEP for the neurophysiological monitoring. I am not discussing the potential disadvantage. Now, anesthetic management of the thoracoabdominal aortic aneurysm repair, from neurological point of view, paraplegia after the TAAA repair, lumbar cerebrospinal fluid drainage, we should discuss arterial pressure augmentation, intraoperative neurophysiological monitoring, spinal cord hypothermia, and pharmacological protection of the spinal cord. So paraplegia after the thoracoabdominal aortic aneurysm repair, the factors which contribute to the paraplegia after this operation: thoracoabdominal aortic aneurysm extent, hypotension or cardiogenic shock before operation, emergency surgery, aortic rupture, presence of aortic dissection, duration of the aortic cross-clamp time. Obviously, more cross-clamp time, more ischemia to the spinal cord, and the chance of paraplegia is more. Sacrifice of the intercostal or segmental artery branches, prior thoracic or abdominal aortic aneurysm repair, prior repair of the type A aortic dissection, occlusive peripheral vascular disease, and anemia. Now, to minimize this paraplegic risks after thoracic or thoracoabdominal aortic dissection, minimize the aortic cross-clamp time is very important. Distal aortic perfusion should be maintained. Passive stand, that is like a goat, should be placed, or partial left heart bypass or partial cardiopulmonary bypass. The main motto is we have to maintain the distal perfusion. Or delivered hypothermia, I'm not going in detail. There are three categories: mild to moderate hypothermia, systemic hypothermia, deep hypothermia, or selective spinal cord hypothermia. Increase the spinal cord perfusion pressure. We have to increase this SCPP. So reimplantation of the critical intercostal and segmental arterial branches. You know, in our setting, my experiments to reimplantation of these critical intercostal and segmental arterial branches are very limited. But normally we do the lumbar CSF drainage when the CSF pressure exceeds the 10 millimeter of mercury, and normally we augment the arterial pressure to like the mean arterial pressure should be more than 85. And intraoperative monitoring of the lower extremity, there is somatosensor evoke potential or motor evoke potential. Postoperative neurological assessment should be done by serial neurological examination, and later on I will discuss this neuroprotection. I'm not going details the arterial supply of the spinal cord, because this is the key factor why we should monitor either the SSAP or the MEP to monitor whether the spinal cord ischemia is going or not. But lower extremity weakness by spinal cord ischemia, paraplegia, there is division 0, 1, 2, or paraparesis. Now, strategy to prevent this immediate onset paraplegia. There are two types of problem. One is just immediate, one is delayed. Now, what are the strategy to prevent the just immediate onset paraplegia? First, the mild systemic hypothermia should be maintained. Lumbar cerebrospinal fluid drainage when the CSF pressure goes above 10 millimeter of mercury. Selective spinal cord cooling, not experiences not much. Distal aortic perfusion should be maintained, minimize the ischemic time. Segmental aortic reconstruction, intercostal artery preservation, and pharmacological neuroprotection. Intraoperative motor or somatosecondary evoke potential monitoring should be done, or arterial pressure augmentation. Now, delayed onset spinal cord ischemia. What are the prevention and treatment of this delayed onset spinal cord ischemia? Maintain the mean arterial pressure more than 85. Serial neurological assessment for lower extremity weakness or sensory loss. Immediate treatment to augment the spinal cord perfusion pressure. Arterial pressure augmentation with pressure therapy, important. Lumbar cerebrospinal fluid drainage and prevent hypertension. Now, lumbar cerebrospinal fluid drainage, class 1 recommendation. Level of evidence B, improves the spinal cord perfusion pressure. It counters the increased CSF pressure caused by the aortic cross-clamping, reperfusion, increased CBP, and or spinal cord edema. It's performed by the insertion of a silicone elastometer ventriculostomy catheter via 14 gauge 2 needle at L3, L4 vertebral interspace. Drainage when spinal CSF pressure exceeds 10. Complication, neurological hematoma, catheter fracture, meningitis, intracranial hypertension, or spinal headache. And arterial pressure augmentation to increase this SCPP. the formula is the MAP, mean arterial pressure minus lumbar CSF pressure is the SCPP. So SCPP should be maintained greater than 70 mm mercury after TAA repair. So that's why the MAP should be 80 to 100 mm mercury. Spinal cord ischemia involves thoracolumbar cord, which is accompanied by the significant vasodilated shock. So during coming of bypass, the vasopressors like norepinephrine, vasopressin, we should keep ready. High dose vasopressor therapy like norepinephrine, phenylephrine, epinephrine, and or vasopressin should be there. Theoretical hypertension must be weighted against risk, that is arterial bleeding. Intraoperative neurophysiological monitoring. Honestly speaking, we don't monitor this SSP or MAP, but the SSP or MAP is recommended to allow immediate intraoperative intervention such as intercostal artery implantation or relative arterial hypertension or CSF drainage. This is class 2B recommendation. SSP monitors either posterior and MAP monitors the anterior spinal column integrity. SSP monitoring is performed by applying electrical stimulus to the peripheral nerve and recording the evoked potential. MOP paired stimuli to scalp and recording the evoked potential generated in the anterior tibialis muscle. So latest thoracic aortic disease guideline says SSP alone suffice for clinical purpose. MAP does not add significantly to the clinical management. Spinal cord hypothermia, not done too much, not done very often. Tropical spinal cord hypothermia with cold saline epidural infusion as a part of multiple spinal protection protocol, epidural cooling as adjunctive technique, that is a class 2B recommendation. So pharmacological protection of spinal cord like brain, that is high dose systemic glucocorticoid, mannitol, intrathecal papaverine, or anesthetic agent, that is class 2B recommendation, or lignocaine, naloxone, magnesium sulfate. But the application in clinical practice is very limited. So anesthetic management for thoracoendovascular aortic repair. This is a new approach where the mortality in the thoracoabdominal aortic aneurysm, the mortality is very high. So the people now they are coming with a new approach with the endovascular repair. So additional concern in this particular approach is spinal cord ischemia and the stroke. If the spinal cord monitoring is planned, that is either SSP or MAP, the anesthetic technique must be designed not to interfere with their signal quality. This factor for the stroke, history of the prior stroke, very important. We have to take note of this prior stroke, mobile aortic arch atheroma, or the TFVR or proximal or entire descending thoracic aorta. This factor for the spinal cord ischemia, the perioperative hypotension, prior abdominal or descending thoracic aortic procedure, and that compromised spinal collateral arterial network, and the coverage of the entire descending thoracic aorta, that is significant loss of intercostal artery. So indication of the CSL lamina drainage in the TFVR, that is planned extensive coverage of the descending thoracic aorta, history of prior abdominal or descending thoracic aorta procedures, post-operative parapedesis or paraplegia despite relative hypertension. And lumbar CSF drainage is strongly recommended for spinal cord protection strategy for TFVR in patients with identified risk factor. That is a class 1 indication. Now, aortic dissection, I am not going in details. There is classification, DBK classification, 1, 2, 3, 3A, 3B, standard classification. These are the pictures.
Dr. Sorry to interrupt. Your time is nearly over.
Just I'll take. Yeah. So I'm just going to straight to this our one video. Recently we have done one this EVITA open plus chain graft system technique. Okay, it is a long video like tool, but I am not going in details. Just I want to say just one thing. This Samom Virot Singh is 47 years from Manipur, presented in our hospital with a history of chest pain 2 weeks back. I mean, just 4 weeks back. We prepared this presentation 2 weeks back, and he was later diagnosed with DBK's type 3 dissection, that is Stanford type A, with a retrograde extension to the ascending aorta and the antegrade extension till celiac trunk, where the celiac trunk was arising from the false lumen. The aortic valve were spared with no AI and the coronaries were normal. So frozen elephant trunk procedure was planned and with the EVITA open plus chain graft. Just I'm giving just a view of the whole procedure. This is a stented, and this is the upper part is the graft. Now, how we did the whole procedure, I'm not going details, but just see this part. The false lumen and the true lumen. Stain going through this guide wire, and gradually we inflating the whole thing. Stain are getting inflated. So when the stain is inside, we suture the stain with the false and the true lumen, so there is no gap. Now we pull the vascular graft that is which was everted. Now we pull the whole thing. Now you cut the upper part and the island technique. We put that all the arch vessels. Okay. So this is in basic. So the final result, this is the final result. And this is the post-op CT aortogram. Patient had a smooth postoperative days, and we off uninterrupted within day 3 and good spiral and effort and no complication. He was discharged on POD 8. So in this patient, we monitored the NEURO. You show the whole period. The right, it was showing the 73, and from the left it is 85, which is above normal. And in another patient, we observed these during the operation. It is the NEURO monitor, and we observed the decreasing part in the right part. So we asked, because there is some problem in the selective antegrade cerebral perfusion in the aortic artery. So we asked surgeon to look into the problem. So later on, he managed the whole thing, and gradually we came up with the NEURO more than 55. So thank you for patient hearing.